It's my pleasure to introduce Pratibha Agarwal. I'd like to declare that she has no conflicts of interest first. Pratibha got her medical degree in India and went to the University of Texas Health Science Center in Houston to earn her MPH. Then she joined us here in Pediatrics residency, where she's done a lot of work. She's done numerous presentations at various conferences. The most recent was a presentation on factors influencing length of stay in NAS babies, which fits in with her career goals of neonatology. She's going to University of Kentucky in Lexington to pursue a fellowship in neonatology next year. So I know we're running a little behind, but please welcome Pratibha Agarwal, who's going to talk about Superbugs.
Thank you for that kind introduction, Dr. Dodd. Okay, so we'll talk about Microbiological Avengers, the Superbugs. These are the bugs that are like superheroes in their own little world. As Dr. Dodd said, I have nothing to disclose. So we will first see how can we define these superbugs. We will learn what are the most common superbugs that we have currently, and how can we identify those superbugs on the sensitivity reports. What are we doing as healthcare providers to contribute to this emerging antibiotic resistance, and how can we prevent this from happening? The reason I decided to go ahead and make this presentation was because as an intern, I struggled with identifying all these superbugs, and I've noticed there are a lot of residents who find it a little challenging to see what kind of a superbug are we actually dealing with. So what are these superbugs? Superbugs are the microorganisms that are resistant to one or more class of antibiotics that are generally used to treat these infections. We all know antibiotic resistance is a growing problem, both in the US and across the globe. In 2013, CDC came up with this antibiotic resistant threats and listed all the possible threats of different superbugs in that report. Each year in the US, there are at least 2 million people who acquire serious bacterial infection because of these superbugs, and out of this, 23,000 people end up dying because we don't have any effective treatment. There was no PEDS specific data for this, it's just for the entire population. Based on the level of concern, CDC divided these superbugs in 3 different levels, 3 different categories. First one was the urgent threats, which means we have not currently seen a very widespread occurrence of these bacteria, but it is bound to happen if we don't take any action. The serious threats are the ones that we actually see right now, and the concerning threats are the ones that may happen soon. Given the time constraint, we'll just follow on few of these superbugs throughout my presentation. So the biggest question is, how does this antibiotic resistance actually happen? Whenever a person takes any antibiotics, a lot of germs, including sensitive bacteria and good bacteria, are killed. At this time, the resistant bacteria are not killed, and after the good bacteria are gone, they now have an environment where they can grow and multiply, and when they have an opportunity, they can lead to an infection. There is also horizontal transmission of this resistance through the plasmid from one bacteria to another bacteria, just increasing the spread of resistance. So overuse of antibiotics is a major modifiable cause of increase in the drug resistance that we see. As we can see on the left side, there has been rapid increase in the development of antibiotic resistance to the most common antibiotics that we use. On the right, we can see the development or approval of new drugs is on the fall. There is no match in this. So now we don't have any new antibiotics to deal with the emerging resistant strains. So we are left in a situation where we have more resistant bacteria, but fewer antibiotics to deal with them. So how can we find a solution to this problem? In order to do so, we have to find a way that we can use to halt the development of this antibiotic resistance and reserve our broad spectrum antibiotics only when absolutely necessary. To do so, we have to first be able to identify any bacteria and then tailor our treatment accordingly and use the most narrow spectrum antibiotics possible. So let's learn how to identify a few of the superbugs. To identify the superbugs, we have to look at the sensitivity reports. The antibiotic susceptibility testing. It's just a report of the sensitivity pattern of a particular strain of bacteria that the patient is harboring to see if it has acquired any resistance to a variety of antibiotics which we may choose in order to treat that infection. What does this report contain? It has mainly two things. One is the MIC, which is called minimum inhibitory concentration. We have to remember it is used, the absolute values of MIC is used only for life-threatening or difficult to treat infections. As a general rule, lower the MIC, more susceptible is our bacteria to that particular antibiotic. The report also contains if the particular bacteria is sensitive, resistant, or intermediate to that antibiotic. Most of the time, intermediate strains are considered as resistant unless we are dealing with an infection where we have no more antibiotics left, or if it's an antibiotic that concentrates in that particular site of infection, then we might end up using the intermediate ones as well. There is a standardization of antibiotic susceptibility testing, which is governed by an institute called CLSI, which is Clinical Laboratory and Standards Institute. It tells us what would be the MIC for different antibiotics and what antibiotics should we use for different bugs. So let's get ready. I have 5 superbugs. I'll be giving you the sensitivity report, and based on the sensitivity report, we have to identify the bug that I'm talking about. Everyone needs to use their phone now and text this, send it to this number so I can get the live audience response and see what do we know about these superbugs. So the first superbug, we have a 10-year-old female with UTI. Urine culture is growing more than 100 colonies of E. coli. Patient is currently being treated with Omnicef, and the urine culture sensitivities are as follows.
Could you read the text?
Yeah, it's not case sensitive. It's TIBHS 374 22333. It's there, if you can see it now on the screen. Don't look at the answers. It was just me and my husband testing if this works. So we'll wait for a few seconds for everyone to answer. Just pick A, B, C, D. Oh, sorry. We'll give some hints. So this E. coli is sensitive to C4T10, is resistant to cefotaxime, is sensitive to tazobactam and imipenem. Just giving some hints there.
Can you go back to the answer option?
Sure. I'm pretty sure there are more than 4 people in the room. Okay. Okay, seems like most of us got the answer right. It is ESBL positive. The reason is it's sensitive to C4T10, sensitive to tazobactam and carbapenemase. So this is ESBL positive E. coli. What does ESBL positive mean? ESBL stands for extended spectrum beta-lactamases. These are the enzymes that can hydrolyze the beta-lactam and monobactam ring structures, but they cannot attack cephamycins. Cephamycins are cefoxetine and C4T10. These are also beta-lactams, but these are not the cephalosporins. These are also not affecting carbapenems. It's important to remember ESBLs are actually inhibited by beta-lactamase inhibitors like clavulinate, sulbactam, and tazobactam. So what are the risk factors for anyone to develop ESBL positive infection? You have to remember, GI tract is the main reservoir for Enterobacteriaceae species. Anyone who has an indwelling medical device, who has been critically ill, having a prolonged length of stay in the hospital, had recent surgery, or had a heavy antibiotic use, the source that I use described this heavy as 6 or more days of antibiotic use in last 6 months. So it's not heavy. It's just simple 1 course of antibiotic. Use of corticosteroids or use of any percutaneous feeding tube. ESBLs are mainly found in gram-negative rods like Klebsiella, E. coli, Proteus, Pseudomonas. So how can we screen for ESBL? We generally screen for ESBL in all the gram-negative rods, mainly for the species of Enterobacteriaceae like Klebsiella, E. coli, Proteus. There are other gram-negatives where we can also check for ESBL, but there have been no standard guidelines set by CLSI how to interpret those results. Detection of ESBL in the lab can be very difficult because these enzymes have different levels of activity against different cephalosporins. Thus, the choice of antimicrobial agent used in the lab is very critical. One ESBL strain may actively hydrolyze ceftazidime, but may have a poor activity on the other cephalosporin. So if any time ESBL is detected in the lab is bound to report that strain to be resistant to all penicillins, all cephalosporins, and monobactam. And the only monobactam we have is for now commercially available is aztreonam. So it is said that labs should use more than one antimicrobial agents while they are screening for ESBL and not just one random cephalosporin. The highest sensitivity has been seen with cefpodoxime and ceftazidime, which are both third-generation cephalosporins. Every time you screen for an ESBL, if it is positive, you do a phenotypic confirmatory testing, which is checking if the growth is inhibited in presence of any beta-lactamase inhibitors, because it's an important point to differentiate between ESBL and the next superbug we'll discuss. So why do we care if this is ESBL positive or not? Because for most of these infections, we'll end up using cephalosporins, and high rates of treatment failure are seen if you treat an ESBL positive infection with a third-generation cephalosporin. In fact, there has been some studies done that has found an association between administration of a third-generation cephalosporin in a patient with ESBL and acquisition of ESBL if it was not ESBL from the beginning. We also have to know the status if it's ESBL or not to define our infection control policies. If it is ESBL, we have to remember the patient has to stay in isolation until 6 months have passed from the last positive culture, or if patient does not have an active infection. And the most important reason is if we know it's ESBL, we know we might end up using our broader antibiotics like carbapenem, but we don't want to use it right from the beginning for all gram-negative infections if they are not ESBL. So how do you treat ESBL? The mainstay of treatment for ESBL is carbapenems. Studies have shown that we have improved outcomes when carbapenems are used in terms of survival and the bacteriological clearance from the body. We have 4 carbapenems available for use. Imipenem and meropenem have similar efficacy. The way we decide which carbapenem to give is just based on the side effects or toxicity profile. For imipenem, it gets hydrolyzed, it gets deactivated by an enzyme in the renal proximal tubular cells. So it's always given with cilastatin, which prevents such inhibition and provides imipenem, the medicine, in the body for a longer time. We end up using meropenem in patients with seizures, pregnancy, or those with renal failure because imipenem lowers your seizure threshold. Doripenem is a relatively new carbapenem. It is FDA approved for more than 18 years old. Ertapenem is the only carbapenem that we have for IM use, so it can be used for outpatient management of ESBL positive UTI. But it says that we should not be using IM or IV ertapenem for any severe sepsis from Enterobacteriaceae species. There are a lot of other options available, like just using a combination with beta-lactamase inhibitor, but this can also give you sometimes treatment failures. Fosfomycin is the other medicine we can use. It's for older kids. It's a PO medicine for UTI. But because we have been using fosfomycin so much now, there is a resistance developing against fosfomycin. Tigecycline is similar to tetracycline, used in more than 8 years old. Fluoroquinolones, aminoglycosides. But they say try not to use these drugs as monotherapy. It's time to talk about our next superbug. This is a 10-year-old male who's been admitted to PICU for septic shock. The blood culture is positive for Proteus, and following is the susceptibility report. We're doing the same thing like we did last time. Look at the sensitivities, and we'll be identifying what kind of superbug this is. So you just have to type in A, B, C, D, E. I'll show the, similar to what it was last time. Don't look at the results. It's just me and my husband testing it. So I'll give some hints again. It is resistant to cefoxetine. It is sensitive to cefepime. It's resistant to tazobactam. and it is sensitive to imipenem. So a lot of differences if you compare it with the previous sensitivity report. Are we? Okay. It was sensitive to imipenem. So okay, just a hint. It is sensitive to imipenem, which is a carbapenem. I think few of you guys got it right. It is AMC positive. So as I said, it is resistant to cefoxitin, which is one of the cefamycins. It is sensitive to cefepime, and it is resistant to tazobactam. So this is AMC positive Proteus. So who produces AMC? Just like ESBL, it's not all the gram-negative rods, but most of the gram-negative species like Klebsiella, Salmonella, Proteus, E. coli will produce AMC. It is unnecessary to detect AMC production in organisms that already have the chromosome for AMC production. It's not going to be helpful because we know for sure they are AMC producers. It is also not important to identify AMC production in such organism because the identification of the organism itself is indicative of AMC production. Like 100% of Enterobacter cloacae and E. aerogens are AMC resistant. CLSI also does not recommend testing for AMC routinely because even if the test is negative, that does not exclude the possibility of the microorganism acquiring the resistance upon exposure to therapy with third-generation cephalosporins. And we would anyways avoid using third-generation cephalosporins in a septic patient with Enterobacter ECA infection because these microorganisms are already resistant to third-generation cephalosporin most of the time, especially given the patient is having severe sepsis. So how do we end up treating AMC positive infections? It's very challenging because, as I mentioned, even if the strain is not AMC positive to begin with, it might become AMC positive upon treatment. The difference between this and ESBL is you can actually use the fourth generation cephalosporin, cefepime, to treat AMC positive infections because it's a poor inducer of AMC beta-lactamase and it has reduced affinity for the beta-lactamase. So it won't be affected by the beta-lactamase enzyme. Just like ESBL, carbapenems are the mainstay of treatment for AMC as well. There is no significant difference in the mortality or length of stay when you compare cefepime versus carbapenems for AMC positive bacteria. Very important for us to know because we care a lot about ESBL. For AMC, there is not much we can do, but we have to change our treatment for ESBL. So have to know the differences, how to identify these two. As I said, important are cefamycin, cefoxitin, and cefotetan. AMC are resistant to those. Sensitive to cefepime, which is a fourth generation cephalosporin, unlike ESBL, and resistant to beta-lactamase inhibitors like clavulinate. So let's proceed with our next superbug. This is superbug number 3. So here we have another sensitivity report. This is a 10-year-old female with complex medical history. She's admitted to PICU for bacteremia. Respiratory culture is positive for Klebsiella pneumoniae, and this is the sensitivity report. We have to again identify the superbug. So look at the sensitivities closely. Let me know when you guys are ready for the next slide. Okay, so here are our options. So we want to look at the sensitivities again?
Yes.
Okay, going back to our options. Seems like no one knows the answer, or everyone got the right answer. One of those two possibilities. Okay, so whoever answered that was correct. It is carbapenem-resistant Enterobacter ECI, so it is KPC positive. We'll discuss about what it means. So carbapenemase is also just a beta-lactamase, but unlike other two enzymes that we learned about, these would hydrolyze even carbapenems. These are mainly produced by Pseudomonas aeruginosa, Acinetobacter, and Enterobacter ECI species. There are different classes based on the molecular enzyme and its function. So there are 3 different types of carbapenemase. Class A, the most common one is KPC. It was isolated in 1990s. It is the most common carbapenemase in the US, and it was first described, as I said, in 1990s in North Carolina. In this class, they hydrolyze carbapenems as well as penicillins and cephalosporins, but they can hydrolyze penicillins and cephalosporins more as compared to carbapenems. Their growth is inhibited by clavulinate, which is very important to know. In the last column, we can see there are different strains or different enzymes, but the most common one for us to remember is KPC. Class B is the second class. They're resistant to carbapenems. The only difference is they are inhibited by EDTA, which is a chelator. The most important to remember from this class is NDM1, which is the New Delhi strain. It was first described in 2009 in a Swedish patient who was hospitalized in India because of a Klebsiella pneumonia infection. The third class is class D. They are very weakly hydrolyzed. They weakly hydrolyze carbapenems, and they are very poorly inhibited by clavulinate. The most common one is OXA. We won't be talking much about that strain. We'll focus on the first 2 strains. So this slide talks about the prevalence rates of CRE in last few years. The darker the color means the higher percentage of CRE isolates have been found in those regions. As you can see, going from top down, as the years have passed, the number of CRE isolates have increased, but still the occurrence of CRE in children is very low. It's like 0.47%. Still, ESBL is the highest one. ESBL is 6 times more likely than CRE in children. Identifying carbapenemase in the lab, there is no routine testing done, no routine screening done for this, unlike ESBL, and it's sometimes very challenging because there is a variability in all different enzymes of carbapenemase, so we don't know which carbapenem to use to screen for carbapenemase production. So detection tests are still evolving, but they are hindered by the presence of heterogeneity in the enzymes itself, as well as the host that they act upon. If any time there is intermediate response to carbapenem, then we consider it as resistant and think about carbapenemase production by that particular bacteria. There are high mortality of there is very high mortality in patients with CRE infections in spite of the treatment. It is close to 50%. We have very limited options to treat such patients, and there are very insufficient data, especially in the peds. So the first option is using prolonged infusion carbapenem combination therapy. Though it is resistant to carbapenem, you can use carbapenem along with aminoglycosides or fluoroquinolones. Research has shown that patients who get this kind of treatment have lower mortality rates compared with this monotherapy with carbapenem. It's almost half than what it would be. The second option is the last resort medicine that we have, which is colistin. We don't have much information about the dosing in pediatrics, but from studies done in adult, we have seen that they have higher resistance rates, and they are very nephrotoxic. We have, there is an ongoing trial in adult patients where they're comparing colistin with a carbapenem and seeing if there is any difference in the outcomes. The third option is tigecycline. Tigecycline is designed to be a poor substrate for tetracycline-specific efflux pumps. So efflux pumps is the mechanism of resistance for tetracycline. To combat that, we came up with this new medicine called tigecycline, which prevents that mode of resistance. It is approved for more than 18 years old. Just like with tetracyclines, we cannot give it in less than 8 years old because of the risk of permanent teeth discoloration and enamel hypoplasia. The last medicine we have for this CRE infections is fosfomycin. As we know, it achieves adequate concentration in urine, so it's very helpful for UTI. There are IV formulation available in few European countries, but here we end up using PO form for cystitis, and that too in older children. There are a lot of other ongoing trials to find a medicine that would work on CREs. The first one is ceftazidime, avibactam. Avibactam, just like the name sounds, similar to sulbactam. It is a beta-lactamase inhibitor. It is active against all the classes of carbapenemase that we saw, class A, B, and D. There is an ongoing trial, phase 2 trial in pediatrics to see the use of ceftazidime, avibactam versus just using colistin for children with urinary tract infections and intra-abdominal infections. The next medicine that they are looking at is ceftaroline and avibactam. Ceftaroline is the 5th generation cephalosporin, but not much information was available about that medicine. So moving forward to our 4th superbug now. This is a 1-year-old male with history of short gut syndrome who's currently TPN dependent, has a Broviac. He was admitted to the peds for bacteremia due to enterococcus. This is the susceptibility report. And the question is different this time. We will identify what does this patient have based on the sensitivity report. The question is finding the treatment for this patient. So let's first identify what kind of a superbug is this. Does anyone know what kind of superbug is this? Yes, you guys got it. So the question is, how are you going to treat this patient? Seems like everyone is very smart today. Or maybe only a few people are answering. Okay, whoever answer is correct, it's linezolide that we'll use to treat this patient. So talking about VRE, enterococcus is tolerant to heat, chloride, and certain alcohol preparations, and they can survive for long periods on the environmental surfaces, which aids in their nosocomial transmission. So VRE is mainly acquired nosocomially. About 30% of the enterococcal infections are due to VRE, and more than 90% of VRE infections are due to the species E. faecium. As we can see on the picture on the right side, there has been significant increase in the incidence of VRE in last few years. It has been creeping up. There are various risk factors that can predispose the individual to getting VRE. The first is having a history of previous use of antibiotics, mainly vancomycin and a cephalosporin. Length of hospitalization. If you have stayed in the hospital for more than 72 hours, it increases your risk of acquiring VRE infection because, as we just learned, it stays on the environmental surfaces. The third is comorbid conditions. So children treated for comorbid conditions were 21 times more likely to acquire VRE as compared to other healthy children. That's what one of the research studies published. So comorbid conditions like cystic fibrosis, immune deficiency, where you will end up giving lots of antibiotics, that is what will predispose them to VRE. And the last is the selection pressure. It is selective pressure means there is a reason for the organisms with certain phenotypes to have either a survival benefit or a disadvantage. So something is happening in the environment which makes VRE to multiply and grow as compared to the other enterococcus strains. So why is it challenging to treat VRE? When I started my residency, I was taught this right in my first month of my intern year, that always remember for all enterococcus, not specifically VRE, for all enterococcus, you cannot use cephalosporins or aminoglycosides. I was taught it like, always remember, no cephalo for entero. So we never use cephalosporins for them. They have an intrinsic resistance to these antibiotics. For VRE, there is accumulation of additional resistance genes because they are also resistant to vancomycin. So we have very limited options to treat such patients. The most common mainstay for treatment for VRE is linezolid. It has been approved for use in children, including neonates. Daptomycin and linezolid are both bactericidal. Daptomycin, it has been recommended not to use for pneumonia. It has been FDA approved only for adults. The reason we don't use it in pneumonia is because it doesn't concentrate in lung, and if whatever reaches in the lung is inactivated by the surfactant. Tigecycline is just like tetracycline that we discussed. It is also approved only for adults, but unlike the first two medicines, tigecycline is bacteriostatic, and we have limited experience in children. The last one is quinapristine and dalfapristine. These are the strepgramins type B. These are not active against one species of enterococcus. So if that is what your culture is positive for, you might not be able to use this. Even this is approved only for adults, and we have a very limited data available for kids. So this brings us to the last superbug for my presentation. This is superbug 5. This is a 5-year-old male with abscess on the right foot. This is the sensitivity report. I'm pretty sure we all can identify what this is. Right? Yes. So the question is not to identify the superbug. The question is, can you use clindamycin to treat this patient? So this is MRSA. Let's see. Can you use clindamycin to treat this patient? If you have to look at the sensitivities again. If you have worked with Dr. Mack, you should be able to answer this question. Okay, let's see. Oh, wow. Good. Okay, so the correct answer is no. You cannot use clindamycin unless you get further reports. So see how it says it's sensitive to clindamycin, but it's resistant to erythromycin. I did not provide any information about inducible clinda resistance, so we'll talk more about it. So accurate detection of MRSA sometimes can be challenging. It is because of the phenomenon called heteroresistance in MRSA strains, where there are two subpopulations of isolates in under the same bacteria in the same culture. One of them is resistant, one of them is sensitive to methicillin, oxacillin, whatever we are using. So all cells in the culture may have the same genetic information for resistance, but not all of them will show resistance in vitro testing. That makes it a little challenging. We all know Staph aureus colonizes the skin and mucous membrane for up to 50% of our kids. Historically, we were using methicillin up until 1960s, but then we don't have methicillin available anymore. So we started using oxacillin in 1990s, and now we are using cefoxitin. Cefoxitin produces better and more accurate results because it is also an inducer of MEK gene. MEK gene is just a gene that is present in most of the MRSA strains, which is the reason for mode of resistance in the MRSA. So what is the difference between MRSA and MSSA? How does MRSA acquire its resistance? Does anyone know? It's just because of alteration of the penicillin binding proteins, and that alteration is governed by this MEK gene. So cefoxitin is an inducer of MEK gene, so it really helps, and now labs, even our lab uses cefoxitin to check for MRSA versus MSSA. So you might not see methicillin or oxacillin on your report, but the way you can identify if it's a MRSA is based on sensitivity to cefoxitin. We are also having PCR test to detect for this MEK gene by itself. So we couldn't answer that last question because we did not know the answers for D-test. D-test it's still been performed, but now the results may be given out as D-test positive or negative, or inducible Clinda resistance positive or negative. So the green is a plate of agar. We have added the Staph aureus bacteria, the culture on that plate. The top one is negative D-test. So we have impregnated the blood agar plate with 2 antibiotics containing disc. One is erythromycin for the E smaller one. The other smaller one with the white zone around it is clindamycin. So we can see this strain is resistant to erythromycin, but it is still, the growth is still inhibited by clindamycin. There is no growth around the clindamycin. So that is negative. What is D-test positive? Sometimes when you have resistant to macrolides, it triggers the expression of enzymes, which is governed by ERM gene, which alters the antibiotic target. So there are some Staph aureus isolates which are resistant to erythromycin. They possess an enzyme which can induce Staph aureus to be resistant to clindamycin as well. So in the bottom we can see there is a positive D-test. Clindamycin was still susceptible, this bacteria was still susceptible to clindamycin, but in presence of erythromycin, the zone of inhibition is blunted. That's the reason you see it's like a D shape rather than a complete circle. So that tells us that it's a positive D-test, which means clindamycin won't work even if it says it's sensitive. So most of the labs either would report this as D-test positive or would say inducible clindamycin resistance present. So that tells you that you cannot use clindamycin for such strains. We all know how to manage MRSA. Based on the IDSA guidelines that I read, they recommended using clindamycin for all the patients that are also admitted to the hospital. Empirically, you can use that as long as your patient is hemodynamically stable and there is no bacteremia and the local Clinda resistance is less than 10%. We know Clinda has both IV and PO formulations available. The other option is using PO Bactrim. We have to remember, using PO Bactrim, you're losing the coverage for group A strep, which is also a very common organism for causing skin and soft tissue infections. The other available option against MRSA is doxycycline. Like other tetracyclines, it can be used only for more than 8 years old. In less than 8, it can give you permanent teeth discoloration. Vancomycin, we have only IV preparation available for all the patients with positive bacteremia, infective endocarditis, osteomyelitis, or any positive endovascular source. You will have to use IV vancomycin as opposed to just using IV clindamycin. Linezolid, we also have IV and PO formulation available for linezolid. Ceftaroline is the 5th generation cephalosporin. It was recently, just last year, was FDA approved for more than 2 months old for MRSA infections, but they recommended not using it for any invasive MRSA infection. So what is our hospital policy? Our hospital screens for ESBL for all the gram-negative rods. We don't test for AMP-C routinely, but based on the sensitivity report, the computer might say, just based on the pattern recognition, they might say, this looks like an AMP-C producer, but there is no confirmatory test for that. They report MRSA susceptibility as inducible Clinda resistance positive or negative, as we just discussed. And we identify MRSA based on cefoxitin and oxacillin, but cefoxitin is given priority over oxacillin. So if a strain is resistant to cefoxitin, but sensitive to oxacillin, it will be reported as MRSA, and both of them would be changed to resistant because we trust cefoxitin more. Cefoxitin is more reliable than using oxacillin. So these were all the threats that CDC reported. Just given the time constraint, we could just focus on few, but as we can see, the list is long. So what can we as healthcare providers do to halt the development of this antibiotic resistance? In the same report, CDC recommended these 4 steps. The first was the primary prevention, just preventing infections from happening. If infections are not happening, you won't have to give antibiotics. You'll probably cut down the development of or spread of resistance. The second was tracking. There is a national healthcare safety network, which is a system that collects and provides data on infections and drug resistance patterns in healthcare settings to see what different kinds of superbugs are now emerging. The third, which is the one we are going to focus on, is improving the antibiotic prescribing or antibiotic stewardship as we know. The last one is, we know the evolution of resistance is partly also a very natural process. The bacteria are growing, evolving, the resistance is bound to happen. So we will always need new antibiotics to keep up with this more resistant strains. So we have to continue the development of new antibiotics. So let's see, focusing on that third point, how can we improve the antibiotic prescribing in our inpatient settings? We all know we have antibiotic stewardship committee that focuses on what are the antibiotics being used, if it is more targeted treatment, what are the patterns of, what are the resistance patterns prevalent in our hospital, and educating the clinicians and everyone making the decision about using those antibiotics. We as clinicians should also ensure that we have selected the correct dose of the antibiotic, the correct duration, and appropriate indications for using those antibiotics. Try to obtain cultures before starting antibiotics. It's not always possible, but if we can, it will help us give a more targeted therapy. We started doing this antibiotic timeout. Every time any patient who's on antibiotic come back in 48 hours and think, does this patient really need that antibiotic? Is this the right antibiotic and the right dose for that patient? On the right side, we can see it's a map of US which shows the percentage of hospitals that have actually implemented this antibiotic stewardship committee. The lighter the color is, the better. So for the state of Tennessee, we have less than 50% of the hospitals that actually have this antibiotic stewardship committee. This was for inpatient. What can we do for outpatient settings? CDC recommends using evidence-based guidelines that AAP has come up with just for the normal problems that we see in our office. For all those guidelines, for my graduating friends, on CDC's website, they have the concise version of all those guidelines. So instead of going through like 10 pages of guidelines, there's just one tabular form that you can use to effectively manage your patient. The second is HEDIS, which is a healthcare effectiveness data and information set. It's a performance measurement tool that has been used by more than 90% of America's health plans to collect information on important things like if the appropriate guidelines are followed or not. The two quality measures they had in the last year's report was if appropriate testing was done for kids with pharyngitis. So the question that was checked for all the healthcare visits was percentage of children between 2 years to 18 years who were appropriately tested for pharyngitis using a strep test, got an appropriate antibiotics prescribed, and the percentage all across the US was 75. The goal was 100%. The second question in their quality measures was looking for treatment for URI. Percentage of children 3 months to 18 years of age with a diagnosis of URI who were not prescribed antibiotics on day 3 of their illness, and it was 87% as compared to the goal of 100%. I compared it with the last few years, and seems like these percentages are going up, but we have still not reached our goal. So this is the graph that tells us the number of prescriptions written for children have gone down in last few years, but still at this point, 30% of the prescriptions written for children are unnecessary or are mainly for viral infections. So overuse of antibiotics is a major modifiable cause in increasing the antibiotic drug resistance. The most common question we get asked in our peds office is, when can my child return to the daycare or school? When a child has been ill and we are seeing the child in our office, we always are asked, they cannot go back to school or daycare until they are on antibiotics. As a matter of fact, I had a patient last week in my continuity clinic who was there because she was sent home from daycare because of pink eye, and mom said they won't take her back until she's on antibiotics for pink eye. So at that time, I had to write on a prescription pad that patient is clear to go to daycare without any antibiotics if stays afebrile. I just found during making my presentation, I found this is a return to daycare letter on CDC website. I think we should all have printouts of this available in our office. You can write patient's name and their diagnosis, and this describes why does the patient not need to be on any antibiotics and is still safe to go to daycare or school. It's just helpful for those parents. So what are the take-home points from my talk? Antibiotic is a very scarce resource. Use it very judiciously. Use it when you need it. Screen all the gram-negative rods for ESBL. Always check if it's ESBL positive or not because it will direct your treatment. All the ESBL positive will need to be treated with carbapenemase. As I said before, no cephalosporin, just a regular enterococcus infection. You can never use cephalosporins for them. Learned that for differentiating MRSA and MSSA infection, we now use cefoxitin unlike methicillin or oxacillin. And the last one is always check for inducible Clinda resistance if the culture is positive for MRSA and it is resistant to erythromycin. So now we have reached to a point where we are running out of options to treat all these superbugs. More and more superbugs are emerging. So I personally think that we are equally responsible because not we as in all the healthcare professionals, we write antibiotics without thinking or not checking the dose. So we should always be very careful with what we are writing and consider ourselves to be responsible for what's happening. So these are my references. Special thanks to Dr. Mack and Robin for helping me guide throughout this presentation. And this is my little puppy who's enjoying springtime. What kind of? Does anyone have any questions? Yes, Dr. Dodd.
I thought that was an excellent talk, definitely an area of increasing concern from a public health perspective. This is kind of you didn't really touch on this, but I'm just asking out of curiosity. Do you know if there's any utility to programs that screen for things like MRSA with nasal swabs and decolonize?
I did come up with that, but I found a research that was done of doing serial MRSA swabs in NICU patients, especially the outborn newborns. So any patient that is accepted in the facility. In our hospital, we do just one-time MRSA screen, but they recommended doing it serial swabs, and mainly from rectum, because they said that's the side which is most likely to be colonized, and treating, because that way you can detect the bacteremia sooner than in the later stages. But I did not find anything specific for peds or anything. Yes, Stephanie?
So I know that there's really not been a whole lot of research and development from pharmaceutical companies into new antibiotics, and a lot of that I think is partially due to not everyone's going to need an antibiotic, and B, it's a short-term med, so they aren't going to make a lot of money off of it. Do you know if, like, with the emergence of superbugs, there's been more interest in research and development for new antibiotics? Have you found anything like that?
I did not come across anything from the pharmaceutical company per se, but in that CDC report, they did mention there are a lot of antibiotics that are currently being tested. But we have to realize that all these antibiotics have to go through a very long chain of clinical trials, different phases, before they can actually be available for use. And then after that, they have to go through PEDS-specific clinical trials before we can actually use it in PEDS. But I did not come across any specific thinking from the pharmaceutical companies regarding antibiotic resistance. I don't know.
There was it's being recognized even by the federal government that new antibiotics needs to be developed. And there was a federal law that was passed in Congress encouraging pharmaceutical companies and even universities to come up with research to develop new antibiotics for the market. That's being widely recognized. In fact, 3 years ago, there was actually a drive by World Health Organization, even by the CDC, that everyone should use antibiotics judiciously for that matter. And in fact, even hospital organizations like JACO, or the Joint Commission is actually mandating hospitals to come up with antibiotic stewardship committee, so that resistant microorganisms will not develop.
Thank you, Dr. Mack. Any more questions? Yes, Dr. Stewart.
So, great talk.
Thank you.
CF kids are just a little bit different. So the CF kids have supervised and you have to get rid of them. So if you don't get rid of them, you cause learning. So it's like different thinking in the pulmonary drug as opposed to therapeutics. Does that make sense?
Yeah. We do see a lot of superbugs because they're exposed to more antibiotics than a regular child.
Actually, you can see the superbugs like Pseudomonas in the NICU
I don't know if it has something to do with their underlying problem of just having cystic fibrosis.
But studies have also shown that if you're not aggressive and get rid of the bug, you turn around and it's not going to work, it's like 5% per year.
Yeah.
Initially it's 20% and then it's 5% per year until they die. So if you take a 5-month-old and you have pseudomonas and you don't get rid of that pseudomonas, you're dead at what, 10, 12? And the goal is 60s.
Yeah. So I think it's important to treat, remembering that they are at high risk of getting superbugs, but we still need to treat. Any more questions? Okay, thank you.